today, my approach to treat IBD. I think after listening to so many talks, there may be some confusion. So now I think Dr. Arun is resolving all the confusions, and he will tell us how to treat IBD, what is his algorithmic approach to treat IBD. So for this talk, I invite Dr. Ramesh Kumar from Hyderabad to chair the session, and may I invite Dr. Sandeep Nijavan from Jaipur, Dr. Giridhar Reddy from Hyderabad, Dr. Ramesh Garg from New Delhi, and Dr. Sanjay Khanna from New Delhi to moderate the session.
Thank you, Team Emerson, who gave me an opportunity to be here, and I'd like to thank Professor Dr. Darish Bansal, who gave me an opportunity. And it's really a pleasure for me to present. Even the crowd becomes thin in the last point. With all the top legends who are being here, it's really a honor, pleasure to present this topic. So, after discussing into the huge area of IBD, how you are going to approach, I am here to take on with few interesting case scenarios in which the few points which have not been highlighted today are few points I would like to discuss along with you all. As you all know, IBD is a chronic entity. Even the best of treatment would not respond. More than 40 to 50% will be having a failure to response to therapy. That's very important. Apart from that, loss of response, around 30% of the patients will be reported. And even if the patient is having good response, how do you going to adhere to the treatment? Whether the patient is sticking on to the treatment, 30 to 40% will definitely go lost when the treatment process is going to get initiated. As you all know, it's been broadly categorized into two major entities. Apart from that, what is the basic treatment goal? Starting from 1985 to 2020, we will be looking into that. So we need to improve the quality of life, limit the disability, heal the mucosa, prevent complications like surgery, avoid steroids and relieve the symptoms. And as you all know, the four major entity will be symptom improvement, your symptomatic remission, endoscopic remission, and histological remission if it's going to be there. And this is all already been discussed in various slides. I don't want to take on to this. See, very importantly, whenever you're going to choose a molecule, when you're going to use 5-ASA, your steroids, your immunomodulators, apart from your anti-TNFs, your anti-integrins, all those things, if you're going to choose, the ideal time for those things to get this onset within the first week of duration, most of the molecule will be taking on. And usually the maximum mucosal layering will be for 5-ASA will be around 4 to 5 months, and steroids within 8 weeks of duration. And for immunomodulators, it will be around 16 weeks, and for other anti-integrins as well as your interleukin-20 pathway blockaders, so it will be around 16 to 25 weeks of duration. And the sequential therapy, as we all been well aware about this, starting from 5-ASA, and we are going up to biologics and all those things, finally the surgical intervention. So the top-down approach, we should not forget when you are going to tackle a patient with IBD. And here I'm going to take on with few interesting basic case scenarios that we are frequently coming across. And this young lady who had bloody diarrhea and in the background of anemia, the patient being diagnosed with evidence of ulcerative colitis, in which we have started the patient on ciproflox with initiating with the basic antibiotics and all those things, and the patient not responding to the therapy with mesalamine and basic prednisolone, followed by the stool frequency tends to get worsened as per your too low weight scoring. So what is happening? So we are being injected going with steroids, hydrocort, and still followed by, when you're going to look into that, the patient clinical scenario, no much of an improvement, and so the patient being evaluated for biological support. After performing the routine screening, TB screening, and all those things, the way the patient being initiated on adalimumab support for a period, the loading dose, the bolus, and all those things. And we are here to assess this patient. See, first the initial picture for before the treatment with adali, there might be more evidence of pseudopolypoid lesions, and followed by after 6 months, the reason has been significantly improved, and over a period of time, within 2 years, almost looking like the normal colon. This is what. But even though if the patient is going to have a significant remission over a period of time, this kind of patient deserves serial follow. That's very important. And few major tablations, that's very important. We need to see, once a patient is diagnosed with Crohn's, always mild to moderate, no major role for 5-ASA, that's well known today. And budesonide, if you're planning to start, look for improvement. No improvement, see through that if the patient is not responding. And moderate to severe, always go with systemic steroids along with your AZO, your immunomodulators. See for response. If there is no response, consider biologics. And apart from that, in the background of severe UC, acute ulcerative colitis, always see whether the patient is proctitis, which means up to 18 centimeters, left-sided colitis, and extensive colitis, which means almost pancolitis. See through that whether the patient is going to be on ASA, or whether the patient is going to be on azathioprine molecule. See, first, left-sided colitis, all the patients start with the ASA, see through that whether the patient is responding or not. If the patient doesn't seem to show a response, start with steroids. If the patient not responding, consider adding immunomodulators along with, if no response, you can go for biologic support. In the background of severe conditions, always you need to consider for CME colitis and other conditions. You can add as rescue therapy like cyclosporine in your management protocol if the patient is not responding. And very importantly, here from WGAJ journal in which we are looking into the trial of ulcerative colitis. So acute severe ulcerative colitis. What is it acute severe? The two low widths criteria has been fulfilling and the patient is not responding to your steroids even after 4 to 5 days, which means the patient is considered as acute severe UC. So at that point of juncture, you need to see, we need to initiate the patient. There are certain protocols of rescue therapy like your cyclosporine, infliximab, and colectomy is being there. And we need to score with the Oxford criteria based upon your CRP levels along with whether the patient is having significant response to the treatment is there or not. Once the patient is going to be a complete responder, then you can continue the patient with steroids and azathioprine. And if the patient is not going to respond, then we need to consider the patient for your rescue therapy or colectomy. So this is another picture in which you are going to start on IV steroids along with we need to see whether the patient is azathioprine naive or experienced a failure. Azathioprine naive patients, if we need to see, we need to consider the patient on cyclosporine even if the patient is having significant presentation of symptoms. And if the patient is responding, okay, we can stay with the cyclosporine, we can continue with azathioprine. If the patient is not responding, then we need to go for biologics and other things to consider. And if the patient is having azathioprine evidence of failure, then we need to give infliximab and see for the response. If the patient is not responding, then we need to go for surgical intervention. And this is what the basic thing. So always, this is what your rescue therapy is there to take on cyclosporine, your infliximab, when you're going to see, assess the patient at day 4 to 7 and switch on to, if the patient is responding, you need to taper cyclosporine to oral and then we can maintain the patient. And if the patient is not responding, followed by infliximab, then the patient need to subject to colectomy. And here, some interesting case scenario. Recently, for evidence of upadacitinib, we have tried 2 major biologics not responding, primary not responsive to your inflexi, readily also loss of response, now moderate to severe UC, and we have been initiated the patient on upada for the past 4 weeks, who had more evidence of fecal calprotectin, clinically worsening symptoms, and for the past 4 weeks, after initiation of treatment, the patient tends to be okay, but we need more and more data as well as time to assess this patient, whether the patient is responding or not. And few interesting case scenarios. What are you going to do in the background of mild left-sided ulcerative colitis? 5 major indications. Mild colitis, always start the patient with a topical aminosalicylate. So, for example, pentazole, enema, whatever things is available. And if the patient is not responding, the next line of therapy, we can go with a topical with oral aminosalicylates. Even if the patient is not responding, you can always add a topical steroids like your hydrocortisone enema. Even after that, if the patient is not responding, you can add budesonide. After that, if it is still not responding, you can go for oral steroid. This is what the guidelines for mild left-sided UC to be considered. And this paper for moderate Crohn's disease with ileocolonic, but still we are having a lot of confusion about ileocolonic. Suppose if there are multiple ulcerative lesions in ileocolon, whether limited ileocecal resection or laparoscopic ileocecal resection as per the trials which is happening in Lyriac paper. So there might be having significant response. One, if you are not going to choose on with that, you can consider the patient with steroids and azathioprine as an add-on role. But if you're planning for intervention like your limited ileocolonic resection, even after that, there might be chances for the patient to recover with the disease. So you need to have a close follow-up. Some patient may deserve azathioprine post-op. Some patient may deserve biologicals post-op. So that kind of patients, we need to have a serial follow-up whether the patient is responding to the surgery. Doesn't mean that if the patient done surgery, the patient is going to respond completely. That one take-home message that we should not forget when you're going to look into the picture of ileocolonic background. In the background of severe steroid refractory UC, very commonly we are coming across this condition. So once you're going to label with steroid refractory, more than 8 weeks, if you're going to initiate, the patient doesn't seem to have any response. At that point, what are you going to do? You can either try infliximab or we can go with IV cyclosporine to go with a dose of 2 milligrams per kg infusion, followed by you can maintain the patient with oral cyclosporine at 4 to 5 milligrams per kg per day, or infliximab at loading dosage, and all these things you can consider. But even after that, if the patient never responds, responding, then ideally you need to subject the patient for colectomy. And very importantly, steroid refractory, very cautious. You need to be about, so other conditions like your, next other common scenario like your Crohn's with perianal fistula. Very simple, identify that severity, so place a set on patient on infliximab support after basic infection control of around 2 weeks of therapy. If the patient is responding, what other biologics can be tried? As of now, infliximab, as per ACCENTURE trials, which has been shown significantly potential role to control your perianal fistulizing complications. Apart from that, Adali, vedolizumab, your ustekinumab is still having a role, but still in the papers where infliximab is still in the higher potential role to document this complex perianal fistula to take on with the management guidelines. And very importantly, with latent tuberculosis. What do you mean by this latent tuberculosis? Before you're going to start the patient on treatment, say ideally, clinically or radiologically, no much of evidence of tuberculosis, but the tuberculin skin test will be positive along with evidence of your IGRA if it tends to be positive. So at that point, what is the definition? This is what, and once a patient, how are you going to approach? You need to do a basic sputum analysis, your X-ray, your CT, your IGRA, and all those things. Sometimes with the patient with CB-NAT and all those things, if you're going to diagnose, you need to initiate the patient on prophylactic regimen. What are the various prophylaxis is available? That's very important. One, INH alone you can consider for a duration of around 6 to 9 months, or rifampicin alone for a duration of 3 months, or INH plus rifampicin, which is a newer molecule, for at least once in a week we can consider. That's by some newer guidelines that we mentioned that for a duration of around 12 weeks of therapy. Apart from that, this is what the basic outline about the latent tuberculosis. But very importantly, if you are suspecting evidence of tuberculosis in the background of Crohn's, other things, always you need to consider other biologics, less of toxicity like your vedolizumab as well as your ustekinumab can be considered like anti-integrin or your other molecules, rather than going for infliximab and anti-TNF, because that can they'll be having around 3 to 5% increased risk of your tuberculosis, rather than going for vedolizumab, which will be having less than 0.5% of risk. So ideally, this kind of background is better to choose on with this kind of molecules. So before concluding, always see IBD is very difficult area to tackle, and overall we need to have a serial response for therapy. And apart from that, even with the best of treatment, around 30 to 40% will be having a significant poor response to treatment. So based upon the clinical assessment, histological parameters, endoscopic parameters, all these things we need to take into account. How are you going to approach a patient with inflammatory bowel disease? With this, I'm happy to rest. Thank you very much.
Thank you, Dr. Arun. Thank you.
Sure, sir. Thanks. Thank you very much, sir.